halos around the light, any flashes or progress. There were no aggregating or relieving factors. Patient was using new glasses for last 5 years. There was no history of any eye drop use, no history of any intravital injection, of the surgery or laser treatment. Coming to the past medical and medical history, patient has been diabetic and hypertensive for past 5 years, 8 years, reported good compliance and control. No history of any chronic obstructive pulmonary disease, asthma or ischemic heart disease. Family history was significant for sister who was diagnosed with glaucoma approximately 10 years ago. He had no known drug allergies. Coming to the general physical examination, he was well oriented in time test person. On ocular examination, his distance visual acuity was 6 by 9 in the right, 6 by 18 in the left eye, best corrected right eye 6 by 6, and in the left eye 6 by 9. His near vision was N5 with glasses in the both eyes. On ocular examination, continuing to ocular examination with visual fields were inspected in all four quadrants as compared to the examiner. Rest of the examination was normal. Coming to the spectrum examination, his cornea was clear, AC was deep and quiet with Van Herring grade 4. However, on conioscopy, he had grade 4 angles in all four quadrants, suggesting open angle. On those Goldman examination torometry, his intraocular pressure was 32 and 30 millimeter of mercury. Fundus examination revealed the vertical cup-to-cup ratio of 0.8 in the right eye and 0.7 in the left eye. There was thinning of the neuroretinal ring, more prominent on the temporal side in both eyes. There was nasalization of vessel at the disc and grade 2 hypertension, retinal also changes, bilateral macula was of This is the fundus picture of the patient. As you can see that there is cupping of his disc with nasalization of the vessels. It's part 8 and part 7 vertical cupping ratio. Now coming to the investigation, we did the visual field examination of the patient. This is the central 22 screening of the patient. However, in the right eye, patient had significant fixation losses, so the result was not significant. But in the left eye, as you can see, the reliability indices are good. The superior field, you can see the outfits scotoma tending towards the temporal side, and inferiorly there are isolated scotomas with relative fading of the left area, which we will correlate with the opacity of the retinal nerve fiber there. You can see that there is thinning of the superior basal of superior, inferior, and temporal nerve fiber there, and sparing of the basal area, which also correlates with the ganglion cell complex OCT. So the primary diagnosis was primary open-angle glaucoma. We had a treatment plan which consisted of rosolamide and immunosuppressive combination eye drops, brimonidine eye drops, and tablet acetozolamide 250 milligrams, one tablet BD. And after the control of intraocular we had planned for therapy. Patient went trabeculotomy in the left eye with phytomycin C 0.4 and G per ml. You can see this is the post-operative picture of the left eye. There's an elevated diffuse left with injection of vessels over it, and there are simple features present at 11 o'clock and 12 o'clock, and a patent identity can be seen in the exterior part of the iris. So these are the post findings: elevated left, surface was smooth, and on definition community, his documentation was 15 millimeter of mercury. So this suggested that the patient underwent a successful left side trabeculotomy in 40 minutes. These are the post-op opacity of the patient, which are showing static changes. And this is the important part of the presentation. You can see this is the anterior segment opacity of the left of the patient. You can see that there is a huge elevated subconjunctival flap. It shows intra-flap cavities which are suggestive of aqueous extending posteriorly in the subconjunctival space. There are no hyperreflective bands suggestive of any fibrosis or scarring of the hemisphere. So we can say that this is a normally functioning active flap. For the other eye, we have planned for right trabeculotomy procedure event for the left eye. Now coming to the discussion of my presentation. Now the crux of my presentation is that this diagram shows all the important steps which are presented in the move field stage surgery technique. You can see that there is a large treatment area superior to the superior aspect of the cornea. This is the large treatment area which should be treated with anti-mortem light. The larger the surface area, the more successful the surgery will be. Followed by a scleral flap, which is partial thickness flap, which should not extend towards the nimbus, which will help us in the most posterior flow of the aqueous. A single scleral punch colostomy by a Kelly's punch, followed by peripheral aerodectomy, and after that, two reusable sutures are placed at edges of the scleral flap, which can be tightened or loosened post-operatively. Now these are some pictures. A traction suture is applied with film 7080 for better view. A phonics-based conjunctival pocket is used. There is another technique called dimple-based, but the results of phonics-based conjunctival pocket are superior as compared to dimple-based. Scleral flap is created with piston knife or a 15 number blade, but it should not extend towards the nimbus, and the dimensions of the flap should be around 5 into 4 millimeters. After the creation of flap, mitomycin C, usually in the concentration of 0.2 to 0.5 milligram mercury, with polyvinyl and 4 sponges are soaked in the mitomycin, and then which are placed in the posteriorly created phonics. It should be noted that these sponges should not touch the conjunctival margin, as it can lead to the thinning of the conjunctiva as well as dimple scarring. Then sclerostomy punch is created using a Kelly's punch. Dimensions are usually 0.5 millimeter, 0.5 millimeters. Followed by conjunctival sutures which are continually in session. This is a small video. You can see that conjunctival sutures are applied here in a continuous manner. So coming to the literature view, wipeout or snap-out phenomenon is a potentially rare complication forming an advanced glaucoma. It is characterized by idiopathic irreversible loss of vision immediately post-op period. Prior to 2000, as the literature says, the wipeout incidence was ranged from 1% to 13%. But due to the newer trabeculotomy techniques, the latest data suggests that the rates of wipeout are between 0% to 2%. So the key points of my presentation are that patient counseling should be done properly. Usually, most glaucoma patients, this would be a complete vision loss if there is no treatment. So patient should be concerned that the chances of complete vision loss following uh, glaucoma surgery are less than 1% as compared to 100% if they are not treated. And applying the new field safer surgery system, especially the tight reusable sutures, help us in preventing post of apportionment and gradual release of sutures later on. These are the references of my presentation. Thank you. Any questions?
Thank you for presenting this case. I must say it's a beautiful surgery. But for me, I'm usually obsessed with the pre-operative examination of the patient and all the protocols that are involved, especially for the residents. So I just want to make sure, did you perform the radioscopy on this patient? Did you? Did you mention it in the presentation? Maybe I missed it by taking data.
I think they were great for anchor on commercial. Very nice.
Another thing, you took a very nice fundus photo. It was showing the disc as well. All fundus photographs, all fundus cameras, they have a feature of a red-free photograph as well. Do you know what a red-free photograph is going to tell us about an advanced glaucoma patient? Very simple technique. You can do it on the slit lamp as well. And on the slit lamp, how you do it? Do you know this? So you can enlighten us about it.
Red-free filters highlights the retinal nerve familiar.
Excellent.
You can do it on any fundus camera or red-free filters present, and usually for any occlusion or any like for lack of a skin or such we can do red-free.
Just to complete the list, actually, I just wanted to complete the list of all the important examinations. And last thing, about the size of the microactive flap. You said that it should be in the dimension of 5 to 4 millimeters. Can you explain it? What should be the width and what should be the vertical?
This dimension should be the width of should be around 5.
Okay.
And the length should be 4, but it should not extend to the limbus.
Yeah, that's to get it. The move will safer surgery. Thank you.
And there's a question.
इसमें वाइफ और नंबर की हम बात की तो आपके पेशेंट में जस्ट फॉर लिटरेचर व्यू यहाँ पे टाइटल भी जो था वो बेस्ड ऑन वाइफ और था उसका क्या आपके पेशेंट के साथ क्या रिलेशन था
हमने बस इसको ये करने के एडवांस ग्लूकोमा जो पेशेंट एडवांस कपिंग का प्रेजेंट करते हैं तो मेडिकेशन में ये पहले प्रेजेंट करके वाइपर हो जाता है तो कुछ सर्जन इसको कैसे भी करते हैं तो जो लेटेस्ट डेटा है वो शो करता है कि जो वाइपर फिनोमेनन की चांसेस है ना वो लेस देन 2% है और लेस देन 1% अकॉर्डिंग टू लेटेस्ट डेटा तो इसके लिए हमें टेबलेट को पोस्टपोन करना चाहिए एडवांस
सिंपल क्वेश्चन है कि आपका फॉलोअप पीरियड कितना था आईए
So usually first post of day we do the intraocular pressure. Then after 1 week we do intraocular pressure. Then 2 weeks or 3 weeks, and then 1 month.
इस पेशेंट का फॉलोअप 1 मंथ
Patient first post of day first week, then 2 weeks, and then 1 month. And patient is present in the hospital. Whenever he feels any discomfort, he comes and inspects.
On behalf of my head of department, Professor Tayyibabul Malik, and the whole department, I welcome Professor Dr. Qasim Nadeem Saab, President of OSP. And now we continue with our presentations. The next presenter is Dr. Hamza Tariq. Could you please come forward?
Slide.
आपके पास सारे हैं ये ब्लैक वाले की जगह
Assalamualaikum. I'm Dr. Hamza Naik. I'm a senior resident from I-Unit 2 and my program is MS Ophthalmology. So the topic of presentation for today is trauma or vascular pain, a diagnostic challenge in people and with hemorrhage. So my patient is a 24-year-old male who is student and works part-time in a shop and is a resident of Lahore. He presented to us about 1.5 months back with some pain of blurring of vision and decrease in vision in the right eye for about 1.5 months. The history of his illness is that he endured trauma about 1.5 months back while forced to closure of the shutter of the shop, which resulted in sudden decrease of the right eye, which was associated with floaters in his vision. This decrease in vision was not associated with any pain, redness, headache, or any other systemic symptoms, or decrease in vision in the other eye. He doesn't have a significant past medical or surgical history except for ankle sprain about 4 to 5 months back, which happened while he was playing football. There is no significant family history except that his mother is hypertensive. The only drugs he has used is painkillers that he used 4 to 5 months back for the ankle sprain and tablet paracetamol on and off. He's a non-smoker, non-alcoholic, and there is no history of substance abuse. He practices good personal hygiene and is physically active. On general physical examination, a well-built young male patient of average height and width, well-oriented in time, place, and person, slightly stable, with unremarkable general physical and systemic examination. On ocular examination, on the very first visit, the visual acuity in the right eye was 6/36 and 6/9 in the left eye. The visual acuity in the right eye was not improving either with any depression or pain. In the left eye, RME was absent, vertical reflex was central, and ocular motility was full in all cases. On slit examination, the edenexa was the normal limit. The right eye had mild hyperemia in the conjunctiva. Cornea was flared bilaterally, anterior chamber was normally depth and wide in both eyes. Iris was in normal color and pattern. Pupils were, as I mentioned, round, regular, and reactive. Lens were faded, and intraocular pressure was seen 14 millimeters mercury in both eyes. On furnace examination, the right eye had a hazy view, and we couldn't appreciate any structures clearly because the medium was not there. In the left eye, the medium was clear, object was pinkish orange, the margins were well defined, it was circular in shape, the cup ratio was about 0.2, and the blood vessels were normal in number and distribution. Macula felt healthy, visual aesthetic, and peripheral fundus was within normal. Now, this is a rescan of the patient on the very first day, about 1.5 months back. My apologies for the quality, but right now. So we can see that there is evidence of vitreous hemorrhage in the posterior segment, but no evidence of any retinal detachment.
नहीं उधर से उधर से एक्सट्रीम मैडम लैंड मैडम लैंड जी जी यार प्रॉब्लम गुजरते हुए चलिए शुरू
Sorry for the delay. Starting from where we left. So the B scan showed that there was evidence of British damage. So that was the reason the CA was not there. But there was no evidence of any technical detachment on the B scan. So we followed a conservative management plan with regular follow-up for the patient, which was doing fine for the first 2 to 3 weeks. The patient presented after 2 to 3 weeks with improvement in visual acuity of the right eye to 6/18, from 6/36 to 6/18, and a resolving British hemorrhage. The retina was mainly attached, and now that the British hemorrhage was resolving, so we could see the fundus to some extent. But there was a suspicion of superficial capsular retinal detachment, but it was not confirmed on that scan. So we continued with the conservative management. But on the subsequent presentation on 2nd June 2026, the patient presented again with flooding and decrease of vision, along with a history of upper respiratory tract infection, which happened during this period, and he had sneezing spells during this episode, during this period. On examination, there was recurrence of vitreous hemorrhage in the right eye, and the B scan of the right eye showed vitreous hemorrhage and a possible traction retinal detachment, so he was admitted for surgical management. Left eye was still unremarkable. This is the B scan which was done preoperatively, and here you can see that there is evidence of vitreous hemorrhage, vulnerability hemorrhage, and there is also evidence of this traction retinal detachment. So it was admitted for surgical management. The plan for the patient was partially amputationally remove the management of suspected retinal enlargement with either segmentation of the abnormal tissue, endolaser and endodermal. But to our surprise, once the British hemorrhage was cleared, the picture was very different. It was not just the trauma that was causing all of this. So during operation, we found that the patient had British hemorrhage of almost 8 intranasal fractional retinal detachment, neovascularization in the intranasal quadrant and nasal periphery, vascular sheathing in the same quadrant, and active bleeding during the surgery. So our approach changed, and this time the plan of management became that we did partial vitrectomy plus endolaser plus heavy liquid plus silicone oil was used to use that as an endotemporal. The heavy liquid was used during the surgery to stop the excess bleed for the time being, so the endolaser can be applied to the surrounding tissues and where the neovascularization are. So these are the fundus pictures that are taken on post-op day 1 with the fundus camera. Here you can see that there is intranasal, still some remnant of hemorrhage in the intranasal quadrant, and you can also see the laser marks that are applied in intranasal region and nasal region. These are the fundus pictures of the left eye. In the center, these small parts are artifacts because you can see that they are comparable on fingertip picture. The left fundus is grossly narrowed, which remains normal throughout the examination on the fundus camera as well. Post-examination on day 1. Visual acuity improved to 6/18. The best corrected visual acuity was 6/12 with minus 0.5 spheric correction. Edinexia was within normal limits. The Taiba had mild hyperemia. Cornea had grade 1 corneal edema. Segment was within normal limits. Intraocular pressure was 12 millimeters of mercury. And on fundus findings, we thought that the cupping ratio was 0.2. Medium was clear. Silicone oil was adequately filled. Retina was flat. Laser marks in the nasal quadrant. Residual hemorrhage in the intranasal quadrant. Left eye had unremarkable examination. First, the plan of management. So we continue topical antibiotic steroid combination, topical NSAID eye drops, regular follow-up for the operator and fellow eye, and complete diagnostic workup for a definitive diagnosis. Because here the story changed. Initially, we were expecting that all of these findings are because of trauma only. But based on the invasive findings, the approach changed. The reason of all these findings could be some vascular therapy. Our differential diagnosis changed. Initially, it was just trauma, but afterwards, we made a complete list of tuberculosis, syphilis, hemoglobinopathy, sarcoidosis, sex disease, intermediate uveitis, idiopathic retinal vasculitis, aneurysms, and retinitis for everyone, and each disease. So we got some investigations done afterwards. These investigations were done pre-operatively as well. With the complete blood profile, the PSR was normal, PSR was 15, LFTs were normal, RFTs normal, correlation profile was in the normal limits, which gives us an idea that there are less chances of any hemoglobinopathy or any bleeding disorder. The chest X-ray was within normal limits. VDR, the test for syphilis also came out negative, RFM was negative, and ANA is negative. One test quantiferon is still negative. So this is a chart that I made for an easy teach one diagnosis easily. This chart is made after review from certain online research papers and from books. The books that I use were Nancy and Oxford and ophthalmology. So for the diagnosis of vascular vessels, the workup that we should follow should be that it can either be a non-inflammatory retinal vascular disease or inflammatory retinal vascular disease. In the non-inflammatory retinal vascular diseases, the common causes are proliferative diabetic retinopathy, which is unlikely in this patient because blood sugar levels are also normal and the age group does not justify the proliferative diabetic retinopathy. Branch retinal vein occlusion, the signs and symptoms that we saw in the studies afterwards also did not show any branch retinal vein. In the inflammatory causes, the primary, I'll come to the primary method. In the secondary causes, in the ocular causes, we have intermediate uveitis. Systemic, we had infectious and non-infectious. Syphilis, tuberculosis, and infectious, and non-infectious would be sarcoidosis and descent. We know that the fundus findings in all of these for example, in tuberculosis, there can be choroiditis or involvement of both retina and choroid at the same time. But in these, we know that. But in other diseases, we know that the presentation is different. In our case, the presentation was not typical of any of these diseases. Now coming back to the primary inflammatory retinal vascular disorder, the idiopathic or isolated retinal vasculitis, aneurysm, and neuroretinitis. The presentation is usually seen in young females, and the patient has aneurysms in the fundus and also neuroretinitis, which appears as a macular starting fundus. So based on these investigations and the presentation of the patient, the most likely diagnosis that we reached up to was Eve's disease. And this is a brief overview of the Eve's disease to have an idea of that why we have more inclination towards this diagnosis. It is an idiopathic occlusive peripheral retinal periphlebitis, which is common in young South Asian males, characterized by three overlapping stages of inflammation. This is a retinal neovascular stage. It is usually bilateral. According to one reference, that study was done in India for over a period of 10 years, from 2009 to 2018, where they reviewed all the patients. They did a retrospective study and reviewed all the patients of UC. And they noticed that 81% of the cases had bilateral presentation. But there are cases where there can be unilateral presentation and asymmetrical presentation as well. Possible association with tubercular hypersensitivity. Clinical features include protein visual loss due to visual hemorrhage, mild uveitis, and often peripheral retinal periphlebitis, sheathing, superficial retinal hemorrhages, branch retinal vein occlusion, microaneurysm, and retinal neovascularization. The rate of recurrent vitreous hemorrhage can be about 1/3 of the eye. Because of these reasons, we have more inclination towards the diagnosis of disease. Now, these are two of the literature evidence that we have. The first one is the most recent and more of a narrative review of studies. It is current understanding of idiopathic pathogenesis, but multimodal imaging and strategies for the disease. This recently published in 2026. Based on that as well, the major of the diagnostic options for differential diagnosis we had were ruled out. So it gives us another idea of the possibility of our patient having this disease. The second paper is actually a patient note, where the patient had a very similar presentation as our patient, but the difference was that patient had bilateral involvement of the eye. There's another point. In the treatment strategies of the Eve's disease, mostly after laser photocoagulation and vitrectomy, they have now added anti-VEGF treatment as well. The first one suggests that tocilizumab is this anti-VEGF. Apply Bertram should be the anti-VEGF, of course, because it shows better results. In the second case report, they used tocilizumab and it showed similar results as well. Till date, there are no record of a vaccine being used as an anti-VEGF for the disease yet. We can, in the later stages of our treatment of the patient, we can add that in the treatment as well if other anti-VEGFs are not available, because in our hospital, anti-VEGF vaccine is being applied regularly, at least 3 times a month. So with this approach, we plan to do more diagnostic workup for our patient in both eyes, so we can reach to definitive diagnosis and we can formulate our management plan accordingly. This further investigation will include having a wide FFA or other investigations, so we can add quantiferon tubercular test as well, because that can quantify and tell us about the status of the patient. So with that, I would like to end my presentation. Thank you so much for listening. Anybody have any questions?
I just want to add, you said the vaccine was not used for eels. This very department you're in, so this was the first department which started using vaccine for eels and other pathologies. So I'm surprised आपको क्यों नहीं मिला? I think वीडियो के अंदर प्रिंट ही होगा आप जाके देखना. So the vaccine for eels हम लोगों ने यहाँ पे शुरू किया था in 2007-8
My point was that it is not used in a way which shows similar results as with other anti-VEGFs. formulate a dosage or a plan where certain number of individual injections or certain interval of injections should be used.
Further, you classify these diseases under the inflammatory vasculopathies. So, bevacizumab, ranibizumab, these are anti-VEGFs. So, do you believe that these anti-VEGFs can help in regression of this disease? Because do you think they have any anti-inflammatory effect? If we consider that it's a purely inflammatory condition, it should respond more to some anti-inflammatory intrathecal injection. What do you think?
So there are certain other organs like dexamethasone in plant as well. Yes, you're right. The problem with CBD itself has a good natural history of the disease, but it can cause certain complications. For example, it can involve and there can be macular edema or there can be neovascularization of the retina. So the antivirus can help with these factors and improve the treatment. So in that way.
If you ask in the history, in the first instance, or after seeing the neovascularization, that any of the family member had tuberculosis, active tuberculosis or not?
Yes, sir,
Who was living with the patient?
yes, sir, I was
This is
very,
important.
yes, I was very particular about this. I looked at detailed family history and even for the business relative, distant relatives as well, he had exposure of tuberculosis ever. Completely denied that.
Great.
You have to put the art off.
Great. Great. It is better to mention it here as well because this is important. And the last thing, if I'm not mistaken, you put silicone oil in the eyeball, right? So post-operative refraction, what kind of AR do you expect? Auto-ref after the surgery do you expect in this patient? If you put silicone oil in a faking patient, what do you expect that auto-ref would be the next day or in the first week, let's say? What auto-ref do you expect?
There are other than showed almost minus 1.5, but I'm not certain about that.
Usually we expect a hypermetropic shift, at least a +4, +6, and the patient starts seeing well with that as well. That's why I was intrigued to ask this. So, okay. Thank you.
Does anybody have a question?
Our next presenter is Dr. Ahmed Salam. Please would you come forward.
My name is Dr. Ahmed Islam. I'm a medical resident in the department actually, experience. And today the topic I'm going to discuss when a smile opens the eye, surgical management of Marcus Gurney jaw disease. First of all, with the disclosure that all the videos presented in this presentation are obtained with the informed consent of the patient and the family. So we begin with the case. So a 19-year-old student presented to us with complaint of right-sided drooping of eyelid and decrease of vision since childhood, and there was also association of movement of eyelid upon the movement of jaw, as described by the patient and her family. To present illness, there was an issue of non-progressive drooping of the right upper lid since birth, associated with decrease of vision in right eye and eyelid elevation during chewing and mouth. Past family history, there was no significant popular history of any systemic illness or any family history in this patient. Patient actually came to us from Afghanistan and she belonged to poor socioeconomic status. So moving on to popular examination, real acuity in the right eye was 660 and in left eye it was 66. Pupillary reactions were normal, pupils bilaterally were round, regular and reactive. Extraocular movements, there was a reduced elevation on the right side, rest of the movements were normal and left eye, the extraocular movements were normal, and her arterial reflex was central, and rest of the anterior and posterior segment examination were also normal, and on autograph, patient was ametropic. There was no refractive error in this case. So moving on to ptosis examination. On the right side, interpapillary fissure height was 4 millimeter. In left eye, it was normal. MRD1 was minus 2 millimeter in the right eye. Ligature function was poor. It was less than 4 millimeter. Upper lid crease was at 11 millimeter in the right eye and 4 millimeter in the left eye. And covenant which was absent. Her bell phenomena was also good. So on jaw making, there was 4 millimeter lid expression during chewing and jaw movement, which was classified as of moderate swelling. So this is the uh, pre-op examination video, which shows the patient having this winking eye movement upon the movement of jaw. So our diagnosis was right congenital ptosis with Marcus gun jaw winking syndrome. So differential diagnosis at this point would have been simple congenital ptosis, front medial null palsy, congenital fibrosis syndrome, myasthenia gravis, but our examination was very clear cut that it shows that it made the diagnosis quite easy, or that of the Marcus gun jaw winking. So we planned a surgery. At this point, like that surgery was done mainly for the cosmetic purposes. As at this age, she was near her wedding, so she wanted to have better prosthesis. So our plan was limited disc insertion and extubation, followed by frontalis sling procedure. So here is the surgical video. We first of all started out by marking the incision site, performing the skin incision. Then we incised the subcutaneous tissue and orbicularis muscle. After that, we carefully excised the levator aponeurosis inferiorly and superiorly up till the vitreous ligament. And here we are removing this levator aponeurosis, taking extra care to remove all the fibers. Then this sling was anchored with a tarsal plate using vital suture, and a frontalis sling procedure was completed. The measurements for the post-op correction were based on our measurements of the fellow eye and on the normal measurement. Here, this frontalis sling procedure was completed. The knots were tied and surgery was completed. So most of here, we advise rehabilitation, antibiotic steroid treatment, follow-up, and exposure monitoring. Because of her visa issues, patient was lost to follow-up. She did not come for a follow-up visit as she went back to her country. But on the immediate post-op day, we were able to achieve good cosmetic results. But patient did not consent for post-op picture. So we discussion. So the Marcus Gunn syndrome was first described by Dr. Marcus Gunn in 1883. It is caused by aberrant connection between the motor branches of the trigeminal nerve, that is the medullary division, and the superior division of the oculomotor nerve. So this leads to a synkinetic movement of the eyelid upon the during the jaw movements. Usually the nerve to an internal and external pterygoid muscle is usually responsible for this synkinetic movement. So that's why the lateral jaw movements elicit the jaw, the winking in most ways. So we grade the severity of this jaw winking. If it is less than 2 millimeter as mild, 2 to 5 millimeter as moderate. In our case, it was 4 millimeter, so we classified it as of moderate severity, and severe when it is more than 5 millimeter. Associated conditions may include strabismus, amblyopia, and isometropia, superior rectus weakness, and surgical management aims to eliminate levator action and transfer the eyelid elevation to frontalis. In our case, as I have discussed earlier, the patient's VM was 660 and she was emetropic, and her rest of anterior and posterior segment was also normal. So the decrease of VM was mainly because of amblyopia, and at her age, we did not prescribe any amblyopia therapy, and the procedure was mainly done for the cosmetic purpose. So key key learning points here were how to assess and elicit this reflex in a patient and to look for this in all cases of doses and to proceed for a proper surgical management and post-op care. Thank you.
Just a comment. Uh, I hope that other doctors might have seen this also, that one-eyed patient, one-eyed in the sense that one eye is amblyopic, so he's not using the eye, amblyopic eye, and he is now in his 40s, let's say. Suddenly he gets a trauma to the good eye, and he's unable to see anything from that good eye due to any reason, and he's deprived of vision in the good eye. You will experience that after some time his amblyoptic eye will start. We have seen it in our practice. So that's why don't use hope, because if the anatomy is okay, if the anatomy is fine, the nerve fiber layer thickness is okay, there is no neurological deficit in the eye. Always expect that this machinery can work again, even after 40 years.
Yeah, I have a few questions. You said that you did experiments and that please continue.
Welcome, sir.
This is an excision. How much did you excite of limiter? First question. Second one, definitely I will second talks of that in my practice. There's two school of thoughts. One says that after 10 years of age, there is no use of patching. The other say no, you can always give a try and trial if you do a better patching and the patient is compliant with the patching technique. They are good results. In my practice, I always advise patient to do patching therapy because I have seen results in, even in adults. So you might have advised her patching therapy, but again, you said she was from Afghanistan and had that she couldn't come back for a follow. So my question is that how much tissue did you excise to elevate it?
From the insertion in the, I think it's in vitreous ligament.
How much?
Almost 4 millimeters, 5 millimeters.
Okay, in my practice, this much tissue, sale of this much tissue is actually of no benefit. Even in the literature, it is said that if you want to do a limited excision, you have to excite at least 10 to 12 mm of ligature muscle, aperture. Next time, if you do this surgery, kindly keep a follow up and you see if you do the surgery and you see how much result did you do you get from excision of this amount of right?
Thank you. Our next presenter is Dr. Ali Raza. Please follow. Dr. Ali.
The topic Lahore, presented on 23rd of May 2020. The chief presenting complaint was blurring of vision in both eyes for almost 20 years, so almost 8 years. And also light vision loss for about same duration of time. According to statement of patient, he was in his state of health about 8 years back when he developed night vision, decreases in night vision, and also the insidious onset of blurring of vision in his both eyes during the day as well.
blurring of vision was not associated with pain, headache, or any other systemic illness. Patient visited multiple ophthalmologists and physicians over the year. However, a proper diagnosis was not made. Patient had a history of pulmonary TB in the year 2022, for which he was treated with anti-TB drugs over the period of 9 months. There is no history of There is no history of hypertension, diabetes, CKD, CLD, syndrome, or any other bleeding disorder. And there is also no significant past surgical history. There is no significant. However, his father started using glasses for near vision for senile cataract. Also, his grandfather complained of decreased night vision later in his life. Patient used isoniazid rapamycin pyrazinamide for tuberculosis for the period of 9 months. However, his control was provided in this. Patient also used antibiotics for the past 8 years. Patient was non-smoker, non-alcoholic, and gave no history of substances. On general examination, he was a tall young man of average height and build. On ocular examination, the visual acuity was 660 bilaterally. Best correct vision was 624 and L80. Usually light reflex was brisk and RMPD was HM. Her skirt was central. Ocular motility was full in all ways. Color vision was abnormal. On slit lamp examination, eyelids, eyelashes, and conjunctiva were formed in normal limits. Cornea was clear bilaterally. Anterior chamber was deep and white. Iris was normal in color and pattern. Pupil was round, retina, and regular. Lens was sleeping in both eyes, and IOP was 18 FSA in both eyes. On fundus examination, media was clear bilaterally. Optic disc was pinkish in color. Margins were well defined, and CD ratio was 0.2 in both eyes. Macula was healthy, and foveal reflexes were present in both eyes. These are fundus picture of patient, and you can see these are in normal units. So, based upon our history and examination, the differential diagnosis were retinal dystrophy, neuromyelitis optica spectrum disorder, chronic relapsing inflammatory optic neuropathy, and Stargardt disease. CPC, LFTs, and RFTs are in normal-limited correlation profile, and CSF analysis were also in normal limits. B-scan, OCT, macula, RNFL, and ONS were also within normal limits. On visual field assessment, there was slight peripheral visual loss, more prominent in right eye compared to the left. In MRI, orbit and brain performed in 2021 and 22 both showed unremarkable studies. PET scan done in 2022 shows hypermetabolic consolidated lung changes which were likely infected. That may be due to past history of pulmonary tuberculosis. FFA done in 2022 was also in a normal limit. ERG done, which showed both scotopic and protopic responses. Both were minimally affected. Visual growth potential study showed demyelination of right optic nerve. Serum anti-lilac oligodendrocyte glycoprotein was done, however, it came out to be negative. Serum anti-alcoporin antibodies also came out to be negative, which showed that there was no demyelinating disorder. So our plan of management was to use visual aid for both distant and near, and continue absence and first phase.
Ma'am, the visual perimetry done in our hospital is, I think, not 100% reliable. Yes, ma'am. Yes, sir. No, no previous history of glasses. He only found out about 8 years back. Uh, दिखाया हुआ था. Color vision was, madam, normal trichromatic in both eyes. Yes, ma'am. Yes, ma'am. Yes, ma'am. Yes, ma'am. For past 8 years, there was no definitive diagnosis made by any ophthalmologist.
Patients will lose hope on the healthcare system, on the doctors, and all the fancy investigations he has been PET scan भी हो गया, MRI भी हो गया. Now the most important responsibility lies on your shoulders to keep the patient's hope alive and keep the patient in follow up with, जैसे मैडम भी कह रही हैं कि something neurological is happening ना. Fields में एक चीज पॉजिटिव नजर आई है और कुछ नहीं आया. Fields रिपीट होना नंबर वन, और न्यूरोलॉजिकल सर्वे रिपीट होना जिसमें इमेजिंग भी आ जाएगी, एमआरआई भी आ जाएगा, और उसमें उसको इस चीज पे कन्विंस करना कि ये तुम्हारे लिए अहम है बिकॉज़ समथिंग ऑर्गन और लाइफ थ्रेटनिंग माइट बी कमिंग इन द फ्यूचर. जैसे वो हमदा की प्रेजेंटेशन थी तो वीडियो सैंडविच के बारे में, टीबी एंड सार्कोइडोसिस आर masqueraders. Sometimes you don't get anything on an investigation in the first instance. You do it afterwards, you get something. ठीक है? साका नोड्यूल्स जो है कई दफा एंगल में छुपे हुए होते हैं, कोनियोस्कोपी से नजर आते हैं. ठीक है ना? तो इसलिए कीपिंग दिस पेशेंट वेल अंडर ऑब्जर्वेशन, इसलिए आप दोनों की वो देखो ना प्रेजेंटेशन को 10-10 साल का भी उन्होंने फॉलो किस तरह रखा होता है पेशेंट का कॉन्फिडेंस बिल्ड कर. यहाँ पे मैं समझता हूँ और भी बहुत सारे फैक्टर्स हैं, बट वन इंपॉर्टेंट फैक्टर इज यू योरसेल्फ. अगर आप पेशेंट के साथ जरा रैपो बिल्ड कर लो ना, उसके साथ जरा फॉलो करो, तो इट माइट बी वेरी इंटरेस्टिंग केस. इट बी वेरी इंटरेस्टिंग. फॉलो करने का तरीका सिंपल है कि न्यूरोलॉजिकल लाइंस को उसको फॉलो करो, समझ में आता है. थैंक यू वेरी मच. थैंक यू.
Thank you very much. Our last presenter for today is Dr. Mohammed Muslim. Kindly come to the stage.
सुविधा ही नहीं और चार हैं तो चारों की तो होंगी, पांचवी यहाँ पर प्रेजेंटेशन की.
Unfortunately, a cold male patient presented with OPD with chief complaint of disease vision and male for the past 3 months.
Past medical history was unremarkable, and past surgical history was the patient underwent a right phacoemulsification surgery elsewhere 3 months back. On slit limb examination, the best visual acuity was 618 in right eye and 612 in left eye. Adnexa was normal, conjunctiva normal, bilateral cornea was clear, anterior chamber deep and quiet. Pupil there was polychoria in right eye and normal in left eye. The right eye was pseudophakic and left eye there was NS1 and process of capsular cataract, grade 1 cataract. Retina was normal in both sides. IOP was 14 in both eyes and bilateral fundus examination was unremarkable. Systemic examination was unremarkable. This is how the patient presented with a small localized iris defect after phacoemulsification. Our surgical plan was to repair the defect with 10-0 proline suture under local anesthesia, Sipser slip knot technique. Here is the video of the surgery. Two paracentesis are made. And the third one, the first leaflet suture is passed through the first leaflet, and it is being passed from the second leaflet with a long needle, and Prolin 10-0 is being used. The other end of the needle is being retrieved outside. Now the loop is being retrieved outside the chamber. Here the knot is being tied outside the anterior chamber, and then it is taken inside the anterior chamber. So it's a closed chamber technique. Basically, Sipser slip knot technique is a closed chamber technique. Second knot is being tied. Suture is being cut. Another suture is being passed from the first leaflet and the second leaflet. And the needle is being passed outside the chamber. This way we repaired the iris defect with Sipser slip knot technique, uh, closed chamber technique. Viscoelastics are being removed and hydro sealing of the wound.
बिस्मिल्लाहिर्रहमानिर्रहीम, अस्सलाम वालेकुम। सबसे पहले मैं शुक्रिया अदा करूंगा मैडम तैयबा का, प्रोफेसर साहब, कासिम प्रेसिडेंट और जनरल सेक्रेटरी अरशद साहब, इन्होंने मुझे ऑनर किया, बुलाया। थोड़ा गला ख़राब है, माइंड नहीं कीजिएगा। सेशन ऐसी है जिसमें मेरे से ज़्यादा, हम सब ज़्यादा लोग एक्सपीरियंस वाले लोग साहब, इनका फील्ड है। आवाज़ आ रही है नहीं आ रही?
So, and then we can proceed forward with the further situation. Yeah, it's not the common this set of lab flat ears, very, very unfortunate. Difficult dissection. Opaque bubble here, not very subpointer or hemorrhage, and so on. अब इस पेशेंट में वीडियो चलती है, वीडियो है, इसमें चलिए वीडियो क्लिक करना पड़ेगा, बस क्लिक करना है। अब हमारे यहाँ अब इसमें लैब डिसेंटर, अब थोड़े से बाहर आ गए, ये डॉकिंग में गलती हो जाता है, कभी पेशेंट कंफर्टेबल होगा, कभी मेरे जैसे इनएक्सपीरियंस बंदा होगा। आपने डाल दिया इसमें, अब प्रॉब्लम क्या होता है कि नल जो है पेशेंट में है अदर कम जाती है बारह, ये हो गया। इसमें क्या हो गया, इट इज डिफिकल्ट टू डिसाइड in particularly the peripheral area where the cornea is best right this way उसमें फिर आपकी रील बनी होती है, you have to dig in और sometimes आप try from the side better side and you will proceed with it। इसमें बहुत प्रॉब्लम आता है, ultimately we have to use this और ultimately हो गया तब ये वीडियो हो गई। अब डिस्कस करते हैं, अब ऐसे में क्या करें, बस देखो रील बनी हुई है, आपको फिर करना मुश्किल हो गया। सर the wasn't because of loss of section के क्या होता है, क्योंकि you can have a descended flap but flap तो सही कटा होना चाहिए ना, तो आराम से हो जाएगा। ये descended होगा section loss हो गया, ये देखा तो बहुत फ्लैट है तो किया था जोन वगैरह, तो वो सेंटेड आपका फ्लैप डिसेंटेड है, अगर आप बेजन करेंगे तो बेजन तो आप सेंटर में बिल्कुल में करेंगे, तो फिर जब अगर वो उसको कवर नहीं कर रहा फ्लैप, तो फिर आधे से में जहाँ पे फ्लैप है वहाँ पे लेजर कैसे लगेगा, तो अगले दिन क्लियर रहेगा, उसको समझ आएगा कि वहाँ उसमें तो हो गया। जब उन्होंने कहा कि पर जहाँ पे आपने एग्जामिन करना तो ये आपका चैप्टर आपने सबसे देन यू कैन वो कर दी होगी, बट इट वाज अ डिफिकल्ट सर्जरी प्रॉब्लम हो गया। मैं अपनी एक एक्सपीरियंस शेयर करूँ आप मुझे फिर जाइए है वैसे कंट्रोल कर रहे हैं, एक बार कर लिया फिर मैं
उसको पहले पूछ लेना चाहिए कि तुम्हें आयरलैंड नहीं जाना। आज जितनी जल्दी होती है ना उतनी प्रॉब्लम होती है, तो इसलिए अपने आप को रिलैक्स करके मरीजों की चॉइस के बाद
आपसे ये वोटर रिया इमीडिएटली आप उसको पर या बेटर टू बी अगर बी घड़ी है और फ्रेश स्टेबल है सरप्राइज फ्रेश स्टेबल नहीं है सरप्राइज आ रहा है तो वेट करें फिर दैट बेटर गो पर आप चीज स्टेबल हो जाए ऐसे रिकट करें डॉक्टर का या यहाँ भी कंप्लीट नहीं हुआ ये सबसे बुरी कम्युनिकेशन है ये एक बार में दिया अगेन क्यों हो सकता है सबसे लास्ट classes embarrassment solution जो है शॉर्ट बहुत जाते हैं सॉल्यूशन उनके शॉर्ट डिपॉजिट हो जाते हैं और वो सिर्फ कर देते हैं उसमें कट खराब होता है तो आप हो जाते हैं फर्स्ट पता कैसे आगे लेकिन आप 3 मंथ्स आगे टाइम जब आपसे दूसरी ये जैसे लगी थी ये परीक्षाओं में not a serious one. है कि नहीं serious है?
I don't know why it calling the complication
problem. बस problem ये करना था कि यहाँ बात कर दिया ऐसा ना कर दो पर जैसे होती है
नजर पे तक करने का वादा किया था
ये मान जाए ये किन लोगों से लास्ट में नहीं जाता होते फ्लैट कर्मी जब कैरेडी बहुत फ्लैट है उसके ऊपर हाईली क्राउड कर लिया उसमें होता है बीच में से कट देगा और आँख की बहुत डीप कट है कटर में प्रॉब्लम में यहाँ प्रॉब्लम ये कट लगे आप नहीं अब ये पेशेंट से 5 दिन करते ये क्या हुआ यहाँ से एपिथेलियल सिर्फ और बेसिक सब एरिया रह गया बाकी सारे आपके सही काम हो गए आप किसका क्या करें
वापस रखिए
बस यही है बस वापस रखिए पहले वाले ने उसे बट हो दिया था तो क्या करने का सारा एक जैसे करना है
जीत कम्प्लीकेशन हो जाएगी ना उसी टाइम ही तुम्हारा
उसने किया ये अभी है उसने किया ये जब मिनट लगाई उसने कहा कि इतना घर बना यहाँ से इतने डीप कट करेगा साइड से कट करेगा आइडिया वो था बट रिजल्ट्स पर नॉट गुड सरप्राइज है
वो है ना वो आइडिया वो अगर एक ही लेयर हो अब एपिथेलियम और है स्ट्रोमा और है स्ट्रोमा ने ग्रो नहीं करना एपिथेलियम ने ग्रो करना वो ग्रो नीचे कर जाएगा वो जी साइड स्किन बन जाएगा
वो बहुत सारे बना और ये कोई थिकनेस ये इसमें भी अटेम्प्ट की गई इसको मैं किधर से उसको स्टार्ट हुआ किसने ले लिया मैं उसने वो अटेम्प्ट की लेकिन फिर छोड़ दिया तो मैंने छोड़ दिया थोड़ा सा ट्राई की मैं इसको कर तो फिर क्या होता है रॉन्ग मसाला तो छोड़ दिया तो बड़ा लोग बन गया तो फुल थिकनेस सब अभी ये दिया कि या फर्स्ट थिकनेस इमीडिएटली कर सकते हैं लेकिन बेस्ट क्या है ये कर और 3 मंथ सही अवॉइड करते हैं बेस्ट है इस केस में टोटली आपने अवॉइड कर दिया मटेरियल लगा के भेजिए अपने आपके पास आए मैं इस तरह को फॉलो करते हैं तो बिल्कुल सही हो जाता है देन 3 बार वेट करें 2 बार 30 पर काट और बड़ी एहतियात के साथ तो ये एप्लीकेशन क्या हुआ ये कटर यहाँ से क्या करते हैं अगर सारा सेटिंग सही हो जाता है पूरी तरह ब्लैक क्योंकि इसमें डिस्कस करने के साथ ज़्यादा असर पड़ जाता है
I'm so sorry जी आपको डिस्टर्ब किया सॉरी आप लोगों को डिस्टर्ब किया। थैंक यू।
Please welcome our working principal, Professor Mohammed Farooq Afzal. The
बस इतना थैंक यू सर। मेहरबानी आपकी शुक्रिया। आपने हमें इज्जत बख्शी बड़ी। जी जी जरूर।
और इसका इसमें भी क्योंकि स्टेबिलिटी तभी आएगी, वरना उसमें बेस रूट के भी कब आपका टिल्ट हो जाएगा। अगले दिन 2 दिन बाद आएगा ये फ्लैप टेस्ट होगा। फॉर 70 मैंने कहा था जरूर लगाएगा। ये तो ठीक इंट्रा ऑपरेटिव कंप्लीट हो जाएगा। होगी ठीक आपने मैंने कर दिया। ये पेशेंट पहले ठीक चला गया, बाद में आया उसका लैब थोड़ा सा फर्स्ट को सर देता है, आप बल्कि कुछ कर दिया स्ट्राया माइक्रोस्ट्राया होती है जो थ्रेड में पड़ते हैं, माइक्रोस्ट्राया का सेल करने से इनका वो डायरेक्ट दैट इज पुलिंग द एरिया। इसकी क्या प्रॉब्लम हो सकते हैं इसका ट्रीटमेंट लैब थोड़ा सा हट गया छोड़ देंगे क्या फर्स्ट कंप्लेंट क्या हो सकती है दवाई ये हो एक और इन लॉन्ग टर्म क्या हो सकता है सम प्रॉब्लम कम्युनिकेशन हेलो जाएंगे बिकॉज़ ऑफ एपिथेलियल प्रोसेस इस दूसरी बात इमीडिएटली आप बताया उसको छोटी में लेते लैब उठाएं अच्छे से वॉश करें देन प्लेस इट फिर दिस पेशेंट कैन वर्क चांस ऑफ क्लियर ग्रोथ एंड कंपेयर्ड टू अदर इस बात चढ़ेंगे उससे काम बढ़ जाएगा तो बहुत फर्क है ये ट्राई आ जाते हैं आप ड्रॉपरेट आ गए पोस्ट आप आ गए ड्रॉपरेट करने के लिए आपने टेक्नोलॉजी नहीं किया 2 दिन बाद आया ट्राई बने but can go wrong with patient if you don't manage. जी क्या करेंगे? फर्क क्या है? Special opinion भी ठीक है, not very very. आप मुझे but क्या है? Track and code है. I better नीचे फिर improve कर जाती है. Not done रहेगा, ये रहेगा, मुझे improve हो जाएगी. बस इसको immediately आपने again इसको कुछ करते टाइम लैब वॉश पे गिरते फिर करें गिरने पर दोबारा देते लैब नहीं रहेगा तो दोबारा वॉश करें इसको नहीं छोड़ना अब फिर खर्च आ जाए वो जो सरकार डेट ये अगली बार की जैसे 2 वीक आ जाती है डेट क्या होते हैं आई हम सब जानते हैं कि नॉट गो टू ये होता है इमीडिएट इम्प्रूव cases are being brought to court. Okay, sir. That is separate activities that we get in the yeah, with the matter that is very very unfortunate. हो सकती है कि process पास करने को गलत होगा पर antibayotic therapy का भी program very rare microbial therapy regression for any process उनमें ज्यादा होगी जिनके हाई नंबर हैं जिनकी आपने टेबल में सही नहीं की जिनका नंबर चेंज हो रहा है उनमें आप वेरी वेरी सेक्शन आपको ग्रोथ very troublesome and very irritating complication for the patient and for the doctor okay patient आपके ही पास आ रहा है और आपको पता है क्या होती है you can recognize very early and you can treat it but as patient very late आती है उसमें आपको जबरदस्त पेशेंट कब आएगा मुझे शेड्यूल से ठीक ऐसा भी होता है पेशेंट भी कम मे बी आफ्टर मंथ मे बी आफ्टर 6 मंथ आपको डॉक्टर साहब अब मुझे से क्लियर मैं
लाइट बड़ी जल्दी कर क्लियर उनके पास बच जाएगा फिर वही इंसान मुश्किल वो सिर्फ डेढ़ स्कूल है पहले स्टेज पे कई से बिल्कुल आप देखिए फर्स्ट आप जरूर चलते हैं आप फर्स्ट हाइप कर हो रहे हैं स्टेज अगेन मान लीजिए मोस्ट फिफ्टी जैसे जो करें Directly is the one in which this hair is progressing towards the center wheel of the axis में आ रही है उसकी तरफ आ रही है इसको अगर लेट करेंगे तो परमानेंट हेयर आ जाएगी and patient is not going to have usual vision as before in the first 2 days after surgery vision कम हो जाएगा वो बाद में ठीक नहीं होगा इसके लिए immediately go for surgery grade 4 जो है फिर तो इसमें ऑपरेशन बन जाती है सिस्ट बन जाती है एडवांस जाती है बट अगेन ट्रीटमेंट इज सर्जरी ये इसमें ये मैं बताया था कंपेयर ऑपरेटर ये भी एक बात है दैट्स अ वेज आगे द ये भी बात 6/24 best printed in 6/24 because of this that was already in the today अभी बड़ी दिक्कत है कि पर जिसके आप बैठे हैं अभी मैं सब पहले से मैंने बताया और जो ऑपरेशन का तमाम में लगे डॉक्टर बताया नहीं है काफी ठीक है ये नहीं रुके कैसे हेल्थ but properly already cared for that the initial crisis also bit over after that is really watching very very gradually इसको आधे घंटे में लगाया एक बार not only that the clear हो गया कि we are better appreciating and it's then don't stop यहाँ से clear हो इस साइड पे उड़ा दो साइड तो स्टेप करें अपनी बढ़ाएं सारी अब टेस्ट हो जाएगा फ्लैप लगा के स्विच लगा दो जो कि इसमें नहीं लगा ये इस बात है दोबारा कंसिडर तो अब सारी उड़ा के वाच करके नो देयर नो एब्सोल्यूट नो तो दैट वर्क्स के रिपोर्ट इसको कटिंग मशीन इसमें भी परफेक्ट सी जाएगी पुरानी परफेक्ट हो चुकी है तो ग्रेड 4 की और इसको वाच करके स्टेबलाइज करके और जो भी हमारे ये शाम हो गई है तो गैप नहीं ये ऑलरेडी सर्टिफिकेट नहीं है ये सही है एंड डन इट वेरी नाइस follow like the plan of the इसका मेन बेस्ट स्ट्रेटजी जो सर्विसेज नहीं पड़ सकता था माइंड हम लोग के लिए पता नहीं अगली अपडेट को बस क्या है जो कि बात फर्स्ट परफेक्ट फ्री ऑफ असेसमेंट वेरी वेरी मैंडेटरी लोग क्या जो ले लेते हैं पेशेंट आगे पेशेंट के जाए नहीं और उसको बहुत सीरियसली लें उसको देखें उसको आज भी मेरे पास कुछ विजिलेंट असेसमेंट ऑफ इंटरप्रेटर उसके ऊपर चाहिए ठीक करने से पहले hold take a breath and then proceed in accordance with the situation of the company कौन सी competition है क्या है और if you are not competent enough call some senior one use continuous that and then get opinion and then let it to be done by डॉक्टर बात करें ना ऐसे कौन से बड़े ये इशू हो गया it is not resolved maybe not put us in some extent but you have to follow the instruction and we are with you and whatever is going to happen or that we will be part of your activity count as rubber जरूरत है हमारे पास रूम जिन स्टाफ का एक बार मेरे को कम्युनिकेशन होगी सही वो कहते हैं कि इसमें हमें छोड़ना नहीं जब भी आएगा वापस दीजिए जब भी आएगा आपने इसको भी पास देनी है इससे कोशिश भी करनी है और ताकि पहले आए हमारे पास ही आए किसी और के पास जाएगा तो किसी आप नहीं कर सकते
हमारी रेपुटेशन खराब हो जाएगी, पेशेंट के साथ रिलेशन खत्म नहीं करेंगे, पर क्योंकि लगता है पेशेंट से निकाल करनी चाहिए। very very nice one वाला था, बहुत अच्छे था। It's very
आप नहीं सुनिए कि निकाह भी करवा देंगे
और में सही बट नहीं दिखाई चाहिए क्योंकि ऑलरेडी कवर हो नीचे हम नीचे अप्लाई करते हैं उसके अंदर एक उतार देना इसलिए thank you very much for patient listening and
हमें कराने का शुक्रिया
अभी तो yes प्रॉपर है और ये
बनी सही बात है।
thank you
Honorable guest of honor, Principal Professor Mohammad Farooq Afzal Sahab, President OSP, Professor Qasim Lateef, General Secretary Professor Arshad Mahmood Sahab, Professor Brigadier Abdul Majid Malik, and dear colleagues, Professor Mohammad Shafiq, Dr. Shahbaz, Professor Election Sahab from Mughal High Hospital, and dear colleagues and very dear Assalamu alaikum. We are honored to have a constellation of ophthalmologists here in Lahore General Hospital, and it's I think after 2 years that OSP clinical meeting is being conducted. अच्छा, एक वो बचपन में कहा करते थे कि एक सुनते थे माओ से कि कुछ कदम होते हैं और बड़े मुबारक होते हैं। तो लाहौर जनरल हॉस्पिटल के लिए हमारे प्रिंसिपल साहब के कदम बहुत मुबारक साबित हुए। लास्ट 1 ईयर के दौरान जितनी प्रोग्रेस, जितनी एडवांसमेंट, जितनी प्रोग्रेशन लाहौर जनरल हॉस्पिटल, अभी मेडिकल कॉलेज और that is amazing. अच्छा, एक और बहुत ज़्यादा टाइम नहीं होगी, टाइम नहीं है। एक छोटी सी हाउस वाली बात बताना चाह रही हूँ। जब हमने की थी हाउस प्रोफेसर लतीफ चौधरी के साथ, अब उस जमाने में लाहौर मेडिकेयर का हमारे जहन में कॉन्सेप्ट होता था कि जो चीज़ दुनिया में कहीं भी नहीं है ना, दुनिया में हमारी एक ये लाहौर और ज़्यादा से ज़्यादा कराची तक भी हमारी दुनिया नहीं, तो जहन में आता था जो चीज़ कहीं पर भी नहीं होगी ना, वो लाहौर मेडिकेयर में होगी। और सर प्लीज अलाउ मी कि मैं आज एक अनाउंसमेंट करना चाह रही हूँ कि हमारे पास 2 ऐसी चीजें आ गई हैं विद द हेल्प ऑफ माशाल्लाह प्रिंसिपल, जो कि लाहौर मेडिकेयर में नहीं है। वन इज एसएलटी एंड द माइक्रो पल्स लेजर, इसकी आज हम इनॉग्रेशन करेंगे। बहुत ही ज्यादा तो इसके लिए हमें एक तो इसका इनॉग्रेशन हमें करना है विद द हैंड्स ऑफ आवर प्रिंसिपल साहब और सारे जो असिस्टेंट कलीग्स हैं। प्लीज आप लोग आ जाएं सर, तशरीफ लाएं।
इनॉग्रेशन से पहले आई जस्ट वांट टू से अ फ्यू वर्ड्स। तो बिस्मिल्लाह, हमारे सब तारीफें अल्लाह ताला की। मैं मीर साहब की टॉक सुन रहा था तो मैंने कहा मुझे तो पता नहीं कितने निकाह करने पड़ेंगे because being a surgeon the complications are not meant to be practice. So even if you are very perfectionist, this is part of unavoidable. Ms. Baker has said so many things. My impression is that we are as a nation brilliant people. Every one of us, Allah has bestowed so many talents. Why it happens that when we work together, somehow or the other we are a collective thing. अगर आपने टीम वर्क पे स्टडी किया हुआ, I was fortunate that I did my MBA during my first principalship. I learned a lot during that, especially from the team. So, if you are average players and you combine together, can perform as a the best. But if you're brilliant players, when you come together, you may fail as a team, collective. So somehow we in Pakistan are facing this dilemma. Whosoever has done this, they have progressed tremendously. जब मैंने यहाँ पे take up किया as a principal, my whole idea, and I just want to narrate why, because I want people the youngsters हैं, उनको ये principle याद रखना चाहिए. It's not about the individual. Individuals ये सारे individual best पर हैं. तो जो चीज़ बेसिबल नहीं है वो institutions. So what we try to do is to try to build an institution जिसका बंदों की आने और जाने से फर्क है. वोट का जो डायरेक्ट प्राइस है उसमें एस्पेक्ट का नाम सुना होगा जिसने किताब लिखी वाई नेशंस फेल, और उसके अंदर सबसे बड़ी वजह किसी भी नेशन के फेल होने की है बिकॉज इंस्टीट्यूशंस जो के अदारे जो के मुल्कों को मजबूत रखते हैं वो फेल होता है. रीजन एग्जैक्टिव जुडिशरी वगैरह. इस वक्त अगर हमारा मेडिकल एजुकेशन इनकाद का शिकार है तो उसकी बहुत ज़्यादा वजह है कि हमारे अदारे जिनको वो रोल प्ले करना है वो उस तरह रोल प्ले करते. एक अच्छा प्रिंसिपल आया, हो सकता है उसने कुछ एक्शन किए हुए 2 साल के बाद जब महीने बाद चेंज हुआ तो वो सारा का सारा था. सो इस सारी माशाल्लाह सारे पढ़े लिखे हैं. थैंक यू फॉर गिविंग अस द प्रिविलेज टू होस्ट यू. मेरा सारे यंगस्टर्स को मैसेज होगा कि यार लेट्स वर्क टुगेदर टू बिल्ड इंस्टीट्यूशंस रादर देन योर ओन पर्सनैलिटी. क्या वो आप सारी उम्र बढ़ करते रहेंगे, अपने आप को प्रोफेशनली डेवलप करते रहेंगे, लेकिन जब तक इंस्टीट्यूशन नहीं करेंगे. तो लास्ट वीक अब मेरे पास काफी ऑप्शंस आए कि अच्छा अगर ये 10 प्रोजेक्ट मेरे पास है तो मैंने 20 को सबसे ज़्यादा इम्पोर्टेंस दी है. मैंने आई पिक कि यार ये जो आंखें हैं ना, अगर किसी के पास सही आंखें नहीं है उसके बाद जितनी मर्जी खूबसूरत बॉडी हो जो मर्जी हो वो बेकार है. तो मैंने अपनी जो प्रायोरिटीज थी फिर डिसाइड की कि मेडिकल नेसेसिटी में कहा यार सबसे बड़ी अल्लाह ताला की दी मेरे नज़दीक, बाकी देखते भी अल्लाह की बड़ी मेहरबानी है, लेकिन मेरे नज़दीक आँख सबसे बड़ी नेमत है. और लॉज एंड हॉस्पिटल से आज कुछ किस्मत है कि इसमें तकरीबन सारी डिपार्टमेंट, ये पहले मुश्किल हुआ लॉज एंड हॉस्पिटल न्यूरोसर्जरी हुआ, दिमाग का सबसे बड़ा अस्पताल. अब हम किसी तरीके से हमारे दिमाग हमारे से छीन लिया, अब हम जो बाकी चीजें रहेंगी उसके अंदर अल्हम्दुलिल्लाह टेक इट प्राइड कि जो जीआई है इवन पीकेआई के लोग यहाँ पे अपना ईआरसीज और बाकी कैसे वी डू लॉट ऑफ कैंसर सर्जरीज, बैरियाट्रिक सर्जरी भी यहाँ का एक ट्रेडमार्क है. तो इस लिहाज से ये बड़ा खुशकिस्मत है. और आई तो एक वैसे एक प्रायोरिटी का था, पहले भी हम अल्हम्दुलिल्लाह ठीक करते थे, लेकिन आई थिंक ये जो नई चीज ऐड हुई है इससे मैं भी एक प्राइड ले रहा हूँ कि अल्हम्दुलिल्लाह हमारे पास अब एक ऐसी फैसिलिटी इकट्ठी हो गई है जिससे वो लोग जो चाहे पहले मायूस थे और सब चीज़ों को नहीं कर रहे थे, अल्लाह ने एक किस्म का हमें वसीला बनाया उनकी खिदमत करने. इतना और मैडम की एफर्ट्स को मैं बहुत सलाम पेश करता हूँ कि शी अलोन वॉरियर, शी आर एफर्ट्स आई थिंक दैट्स द डिपार्टमेंट. तो थैंक यू वेरी मच. मैं रिक्वेस्ट करूँगा कि भाई सारे इकट्ठे हम इसको Hi, sir. Hi, sir. चलिए तालियां बजा के दुआ पूरा दौर में सब कुछ दौर में उसके बाद आमीन जी, सबको बहुत मुबारक हो, खास कर आई डिपार्टमेंट।
बहुत अच्छे केस से लोग बच्चों ने प्रेजेंट किए और बड़ा मतलब था जब से किसको हम नंबर 1 पे एक्चुअली तो ये सारे के सारे नंबर 1 पे ही हैं, लेकिन वो जो थोड़ा सा एसओपी है उनके लिहाज से हमें ग्रेडिंग करनी पड़ती है, उसके लिए मैं डॉक्टर दीप सिंह को थैंक यू वेरी मच सर, और साथ साथ आते जाएंगे वो।
जी बिल्कुल, आज की प्राइस डिस्ट्रीब्यूशन है जी, इसमें सबसे पहले हम लोग बताएंगे जो कि फर्स्ट पोजीशन है जिनकी, दैट इज डॉक्टर हमजा तारिक।
Thank you. The second prize goes to Dr. Ahmed Arsalan. And the third prize goes to Dr. Abdul Fatir. Dr. Fatir. Thank you very much for OSP for the shields. एक prize money है जो सब बच्चे Sir Brigadier Majid Malik Sahab for giving us the honor of his presence and presentation. And And in the end, I would really like to thank Vega Pharmaceutical Company for arranging and managing everything. I would like to ask to please come and receive your certificate. Thank you.